Hi, I'm Metta Spencer. Today, I think it's time for us to give some thought to the prevention of a new pandemic. I don't know that we can prevent these things, but we better look ahead and see what we can do to anticipate and forestall some of the factors that might create new ones, because we're certainly in for a different world where the possibility of pandemic is very much with us. And probably the most promising approach to understanding how we might try to engage with this issue is the approach now being called the One Health approach. And that simply points out something that the pandemic has reminded us, which is that we are all related to animals and to the environment. And we can give our diseases to our pets, and our animal friends can give their diseases to us. So we obviously share many physiological conditions that we could look at as a package and address coherently and comprehensively. So that approach, which is often called the One Health Initiative, is getting a boost now. And today I want to speak with Dr. Lonnie King, who's now a Dean Emeritus of the Veterinary School at Ohio State University. And before that, he has been the the Chief Veterinary Officer of the United States for about 5 years. He was before he became a dean at Ohio State. He was the director of the National Center for Zoonotic, Vector-Borne, and Enteric Diseases at the CDC. And he led their Office for Strategy and Innovation. So you see, he's the guy who has to think in terms of planning what kinds of research we should be undertaking with foresight. And he has edited a new publication, which I have not read and didn't realize existed, but he's pointed it out to us. So we're going to talk a little bit about that publication today and the conclusions that they reached, because it's a very big, important document. Good morning, Dr. King. Dr. Lonnie King in Ohio. Hi.
Good morning, Metta. Nice to be with you.
Very good to meet you. So let's start right in, if you will. And why don't you hold up that publication that we had a little trouble getting it in focus.
This is a new publication that would be available to your listeners. It could be downloaded free. And it's published by the Council of Agriculture, Science, and Technology. So if you went into their website, you could look under publications. You'd see this publication, Zoonotic Diseases in Animal Agriculture and Beyond, a One Health Perspective. So I would encourage your listeners to take a look, and it can be downloaded free.
Did you say Beyond the One Health Perspective?
It's beyond agriculture. So it's agricultural animals, domestic animals, but wildlife. So it's a broader look. But we did include agriculture as part of this publication, looking at the linkage of zoonotic diseases and the impact of agriculture, and some of the recommendations from them.
Okay, why don't I like to cheat by looking at the conclusion of a murder mystery before I read the murder. So let's do that today by jumping straight to the end of your publication and find out what your conclusions are.
Okay, we'll do it. Let me just maybe spend a minute in grounding that to get to the conclusions, which may make it more meaningful for people. Mm-hmm. So you can look at this publication as a story where the recommendations, where we're headed, Metta, is kind of the next to last chapter. And the idea is that the final chapter is yet to be written. And it is based on our ability to implement these recommendations in a timely way and get them done, so that the final chapter just won't be a repeat of the last 30 years of a remarkable emergence of infectious diseases. So this publication is, as I said, is like a story. So we talk out with the idea that there was three major epidemiologic eras. One started 10,000 years ago, and it was the advent of agriculture, where People changed from being hunters and gatherers into agriculture communities where they became stable. They interacted together, they were connected, and importantly, they domesticated animals. So that point in time, 10 or 12,000 years ago, was the point in time where we really started to see, as far as we know, the major increase in these zoonotic diseases. So zoonotic disease is simply a disease that goes from animals to people. So that was 10,000 years ago.
But would you call it a zoonotic disease if it goes from people to animals?
So it's not zoonotic, but it is a disease pattern called anthropognosis, which we know does occur, including, COVID, for example. So yes, they go back and forth, but when you talk about pure zoonoses, it's from animals to people. But yes, the pathway goes both ways. Mm-hmm. The second big epidemiologic era then was kind of industrialization, where we started to see a reduction in infectious diseases, in deaths due to infectious diseases, and new diseases emerging during this industrialized age over the last 150 years or so. Diabetes, hypertension, cancers, obesity. So diseases, as people lived longer, their life expectancy increased. They were infected and impacted by other health conditions. And at that time, in maybe the early 1970s or earlier, people thought, well, infectious disease era is over. We have vaccines, and that was very premature. So
you've mentioned already some things that surprised me, because I didn't know that there's been an upsurge in some of the diseases. Hypertension and diabetes are more common now than they were, say, a few hundred years ago.
Yeah, if you look over time, I mean, life expectancy in people has changed quite a bit. So the ages, so the things that we see in older people and in their lifestyle is very different today than it was 50 or certainly 100 years ago.
I see, but if people had lived as long as then as they do now, they would have also had hypertension, et cetera.
Well, perhaps it depends on their diet, it depends on their lifestyle. There's a lot of other factors here. But so it's a good question. But which led us really into the third epidemiologic era, which started, 25 or 30 years ago, where all of a sudden we saw an increase in new infectious diseases called emerging diseases. And all of a sudden there was a major increase now in infectious diseases, in mortality of people, and in the number of pandemics or epidemics that are taking place. So we believe we're living now in the third major epidemiologic era over the last 10,000 years, but this just started 25 or 30 years ago. So we're working as, well, why did that happen? What are the factors that created this new era? And so there have been several publications, a couple out of the National Academies of Science, they really talked about microbial threats and how our world has changed and what those factors are. And, we just, last week or so, hit 8 billion people in the face of the earth. So at least 1 million people are joining the face of the earth every week and more. We've produced over 60 billion animals last year, raised and killed for food. And we've created this amazing kind of 21st century mixing bowl of people, animals, and products that have come together. And we've created an environment and an ecosystem which we have changed for the worst. So land use, international travel, climate change, breakdown of ecosystems, poverty. So they've all created what we would call the perfect microbial storm. So these are the factors that are swirling around. And in the center of this storm are new microbes that have emerged in plants and animals and in people in a rate that we've not seen before. So this is this new emerging disease era. And what we do know, Meta, is that about 75% of new human infections over the last 30 years have been zoonotic. So that is huge change.
And that is a higher proportion than was the case before.
Well, except for 10,000 years ago when that happened. So these are the factors, this interconnectedness, the complexity of our world, the global food system, the movement of people and animals and livestock. So it gives the microbes a wonderful ability to adapt, and they have a competitive, competitiveness that we've not given them before. So these new diseases are emerging. Most of them come from or through animals, and that's why we've kind of wrote this publication. And to say that, wow, this complex world is about people and animals, and environment, and crops and plants. We need to look at a different paradigm or a different approach to understand this problem, but also probably to bring forward new interventions and new strategies, because we can't look at these singularly and without looking at all the domains together. And so as we move into the recommendations, they really are about this One Health approach. Things we do in animals and in our environment impact the health of humans, and vice versa. So the idea of just looking at a single dimension of human health in this complex, interconnected world now may not be the right way to really address these. Maybe we need to move upstream. Maybe the interventions are changing our ecosystems or changing our animals or vaccinating them to reduce this ability for these microbes to jump across species lines.
Okay. Well, how much is that really understood? I mean, if you were to put weights on these different factors, would you be able to say it's mostly because people are now encroaching into, for example, territory that had been reserved for wildlife before, and now they're more in contact? Or would you say it's mostly because of travel? Or would you say that we're eating animals that we shouldn't be eating now? And I mean, what do we know what are the real priorities in if we were ranking the causal system of this increase in zoonotic diseases?
So I think there's two. The factors you talked about are all real, and they are occurring, and they are producing, zoonotic diseases. I think there's two things that have changed over the last 25 or 30 years that have moved us into this new era. And number one is our interconnectedness. We are interconnected like never before. We have 1.8 billion people moving internationally next year. We have a food system that is global. When you sit down in, I think you're in Canada or wherever we are, your food doesn't come just from Ontario. You have systems from around the world that are bringing foods into you. So our interconnectedness of people, migration patterns, and the speed at which that happens. So you can move around the world faster than the incubation period of most any of these microbes. So it is that the idea that, a threat anywhere is a threat everywhere. And so our world is connected. The speed of which our interactions take place have gotten ahead of our ability to prevent these diseases from occurring. And we really need to rethink and re-strategize to prevent the next epidemic and pandemic.
Well, I have to react as a political sociologist, which is what I'm supposed to do. And that is to say that the systems that we have, the political systems that we have for addressing problems, are not treating this as it should be addressed. That is, if you say that we're interacting much more globally, the reality is we're putting up walls and barriers and as fast as we can. The relations, for example, between Russia and the rest of the world, for example, we're now, making it twice as hard for scientists to even speak to each other as they would have been able to do a couple of years ago. So and I wonder, there is this thing called the World Health Organization. Is it set up with enough decision-making power to actually decide properly what research agendas and what interventions to promote and where to go to catch people who are creating more risks, et cetera? I'm asking a whole bunch of questions all at once, but mostly my concern is you're talking about increasing human interaction and interdependency, and I'm seeing that the world politically is moving almost as if it were going in the other direction. Am I wrong, or is this my paranoia?
I mean, I think you're right and wrong. You know, you're the sociologist, I'm not, and you have that expertise. So this inability to connect scientist to scientist and to be able to put together global strategies is we certainly still are in a siloed world, which doesn't help that. But I think that I see a new change taking place. For example, 2 weeks ago we had a meeting in Canada on G7 scientists on One Health. Well, think about that. Okay, this is about policy. It's about attention. It's about potential resources. The G20 has come forward and said, One Health is the approach we need to tackle these complex interrelated problems, Meta, that we're talking about, because the old systems don't work well. So if you look at your 6 challenges that you're working on, one of which is pandemics, we call that wicked problems. Mm-hmm. So, you've heard that term. It's actually a business term, but it's the idea that our world now is so interconnected and so complex that old strategies don't work very well because they were set up at a time that we were still siloed. And new strategies haven't really been produced in the way that we think would actually stop these pandemics. So these wicked problems are here, and they're born out of society, and they're complicated, and they're not yes or no answers to them, and they're enigmas. But they are the problems of today, and they will necessitate new ways of thinking, new ways of organizing, new relationships, and new strategies to really focus on these wicked problems. And emerging infectious diseases are wicked problems. And One Health then becomes a strategy or an approach, if you will, to start looking at wicked problems in different ways because the old solutions don't work as well.
Okay, well, what came of that G7 meeting besides just the recommendation that the One Health approach be promoted? Are there specific policy recommendations, or in terms of organizational recommendations that came out of it that we may see implemented?
So we may in the future. I just wanted to use that as an example that all of a sudden, rather than being separate, we are now bringing scientists together from different countries to start focusing on this in a different way. Mm-hmm. So I think that's a positive part. Canada did a strategic plan on pandemics. The G7 that had the meeting that took place took some of those strategies and started to drill down and understand them better as we move forward. Food security, food safety was one of those, mitigating risks. The other one, very interesting, is the role of Indigenous populations in Canada in understanding One Health, which, by the way, they believe they've been doing for millennia, and they probably have been, and some of the wisdom that can be derived from Indigenous populations as we move forward. Because if we are looking at different relationships between our environment, our ecosystems, our animals, our people, our food systems, et cetera, our Indigenous populations probably have unique insights for us. Okay. And so part of that meeting was we need to gain those insights and that wisdom. Rather than to create something that's brand new, maybe we already know what that is. And that relationship between humanity and the natural world, I think, is, I think our Indigenous populations can help us a lot. And so that was part of that meeting. So the idea that you're a sociologist, and I'm not sure, Adam, your specialty, but the idea of One Health is the idea of multidisciplines having to come together and to create new innovative ideas and discoveries that each discipline by itself can't do alone. Mm-hmm. Mm-hmm. So that interaction then, whether it's G7, G20, United Nations, World Health Organizations, et cetera, or United States government and the Canadian government working together, opens up new possibilities. But we need to get out of these stovepipes and this idea of single strategies and single disciplines being the answer. Our world is too complicated now. Mm-hmm.
Okay, there are two things that occurred to me, mostly having to do with not only you've been thinking chronologically, different sequences or stages of world health, it looks to me as if, from what I hear, there are regressive concerns too. For example, the problem of the misuse of antibiotics and the fact that we may be up against a period when our great breakthrough of antibiotics has run its course, and we're back to the Stone Age as far as being able to stop the spread of pathogens. And the other even longer term regressive movement, I've just been coming across people saying that the melting of the permafrost in the Arctic is exposing viruses that may be millions of years old or hundreds of thousands of years old, and which may still be lethal. I don't know whether either of these things, these concerns, is a priority for people working in the One Health field, or is it just something that the press has picked up and magnified into a problem when it's only imaginary?
Well, that can happen, as we know. Certainly, antimicrobial resistance is one of the key areas that I've looked at that is a serious problem. And that's a problem now because it's a problem in our animal populations, a problem in human populations, and the movement back and forth of antimicrobial resistant pathogens or genetic material and the contamination of our environment. So we may actually impact our plants, our crops with antimicrobial resistance because of this interconnectedness. So right now, if you look at all the countries in the world, most of them have major plans for tackling antimicrobial resistance, and they're all built on One Health. The idea, if we need to focus on animals and our judicious use of antimicrobials there, we need to focus on our use in humans. We certainly are overprescribing antibiotics. People are not taking them in a way, they're either taking them too many or not enough or at the wrong timing. And then our environment, where we have our waterways and our water systems now being contaminated, and people are exposed that way. So you can't focus at any of these single domains. It is now, how do we put a strategy together? And I would say, it's not regressive as much as we thought. For example, United States, starting in 2017, really banned the use of human important antibiotics for growth promotion in animals. So that's no longer the case in the United States. It dropped the use of antibiotics about 40%.
Say it again. What is it that this change that has it's already been done?
Livestock and poultry used to be fed antibiotics to promote their growth. And in the United States now, FDA has determined that we've banned that. And if their antibiotics are important for human use, they no longer will be used in animal agriculture for growth promotion. They could still be used for an outbreak of disease, but they'd have to be supervised by a veterinarian. So that is changing around the world. That's certainly the case in Europe. It's certainly the case in Canada. We're starting to see this now change. There's programs called stewardship programs, which are the ability to say, do you need this antibiotic or not? And if you do, is it the right one? Are you taking it in the right dose or right form? And are you taking it for the right period of time? And are you making sure that there's no adverse effects? And that strategy then is a way of thinking about, should I be doing this? And what is my responsibility to move it? It doesn't say you not to do it. It just says a lot of antibiotics prescribed for viral infections that really do nothing, except will create more antibiotic resistance. So the CDC a few years ago said that 30% of the antibiotics used in the United States in human medicine were inappropriate and unnecessary.
Mm-hmm. Well, I've also heard, I think probably the most difficult challenge anybody would ever try is when you try to change what human beings around the world are doing. You can make a lot of changes in the lab, but when it comes out to what people will do when they're sick and think that they know what to do to cure themselves. I don't know, because I know that in many countries antibiotics are sold like candy. Anybody can buy it and use it however he pleases. How are you going to stop that? And is there really? I wouldn't think that that is something that can be prevented, because you got to make sure people have more sense than most people actually do.
And there are parts of the world where they don't have access to antibiotics, and children and infants are dying because of that.
Okay.
So you have two extremes here.
Mhm.
I think that we have to be careful that if we make things so difficult that you can't get your arms around them, then people just kind of throw up their arms and say, well, gee, we can't do anything about it. That's the mistake that, we want to be careful we don't make.
Mhm.
If they're small incremental steps, they're helpful. And we just need to do more of those. This is a huge strategy. It's complicated and complex, and it's going to take time to kind of put these strategies together to make progress. I think we are making progress, but I think this rethinking, and I couldn't agree with you more, that, in studying antimicrobial resistance, one of the things that we've not studied enough is human behavior and the social and behavioral sciences.
Mhm.
That, to me, is as much as a key of just having antibiotics accessible. So why are you making this choice if you know it's wrong? Why do you continue to smoke if we know it's not good for your health? So you're a
Why do you refuse to
sociologist and a
take?
behaviorist. That is part of the strategy for understanding what we need to do here.
But it's not an easy answer. I mean, the simple question, why do you refuse to take a COVID vaccination? That right there, is the most baffling social research that I can imagine, because it's still a point of amazement for me that people would reject treatments that they know, or they should know, would work.
It's just the
So, yeah.
behavioral problem, right? You're right.
Yeah, okay. Well, now let's go back to the recommendations coming out of your new publication. You say you're not going to write the final chapter until it's happened. So we see how it came out.
Go ahead.
Go ahead.
Go ahead. When we kind of wrote this story, we kind of started it with a quote from Shakespeare. The past is prologue. So we know over the last 25 or 30 years what has transpired to create this exceptional new environment in which we live, where microbes are adapting and new diseases are emerging. So what past is prologue is, we know the past, we know where we are today, but that doesn't mean just because the past is prologue that the future is predetermined. So if we make the right changes and are implementing them, we can create a new chapter that just isn't a progression of new diseases, new pandemics, and new threats. So the final chapter is not written because we don't know if we've actually done the right implementation of the right strategies. Mm-hmm. So we've created the last chapter that talked about, well, what are some of these strategies, Meta, that you've been talking about? And the first one would be changing the narrative. Okay, so think about this. The narrative is a capacity to justify and legitimize a cause. So, at least in the United States, I think we've been guilty of quickly forgetting, lessons learned. So when we have a new epidemic or pandemic, we kind of relearn anew. Our memory has kind of dissolved, and we don't understand kind of what's been successful in the past and what's not. So the idea of changing the narrative is this isn't kind of a one-off. These diseases are part of our future. They're going to come more rapidly, and they're going to be more consequential if we don't do something differently. So the narrative is this is about global security. This is about national security, whether it's in Canada, the US, or whatever we're talking about, right? This isn't some disease in West Africa. These diseases now, $20 trillion into SARS, into COVID, mm-hmm. have given people the idea is, wow, these big pandemics are as much social as they are biomedical. And we need to understand that we need to make some changes. And that narrative is this is much part of our national security as traditional war.
Mhm.
It costs $20 trillion. That's more than most wars, right? So we need to think about this in preparedness.
Hold on.
Yeah.
You gave a number, $20 trillion.
We're just guessing what the cost of COVID is, somewhere between 15 and $20 trillion if you talk to global economists.
Mhm.
So, and it's impacted the world for the last 2 or 3 years. Well, that's every bit as important as as a battle, our traditional battle. So we better spend money, attention, and time to prevent these things from occurring, just like we are preventing wars from happening. So that narrative is, oh, wow, this is part of our national security. It doesn't just impact health. It impacts economics, it impacts trade. All of these things now are mixed into that. So we need to really think about, the social disruptions and economic changes. And this is a national security strategy and a preparedness strategy. And we just don't wait for the next pandemic to occur. We prepare proactively. So that's the first one. The second one is to create a One Health surveillance system. So if we don't have, situation awareness, we don't know where to put our resources. We don't know where to look for the next problem. So we just sit back and wait until it happens and then respond, too late. I think the idea of putting a surveillance system in place, and by the way, we have some of these, but to be able to say, wow, we can detect early new diseases coming in animals that may be zoonotic, or we can detect changes in the environment that may be conducive to lead to new interfaces and the emergence of new diseases. But we need to understand and do surveillance on these microbes in these multiple settings so that we know where to put our resources and our time, and attention. And what this means is that...
Let me ask you, are you thinking primarily of catching an outbreak quickly, or are you thinking more in terms of finding a problem area, say an ecological environment that looks problematic where you think something might emerge? Is that kind of more general, or is it more specifically watch the news? Where is a new outbreak of some inexplicable malady occurring so we can get there quickly? Or
so
both?
It's both. And it's a matter of capacity and capability. So now we actually have the capability to be able to put systems in place to look at water systems or some animal populations or human populations, especially in lower and middle income countries. That's the most vulnerable population. That's where we need the help. So if we knew what their threats were, not only can we help them better, but then we would start to mitigate this threat globally. But we can't do it just in human health. We need to do it looking at our animal populations and our environment. And we need to especially focus on low and middle income countries because that is probably where the emergence of the next, major epidemic or pandemic is likely to come from. So that first part is to be able to do that. We can. The second part is we now have the ability through data analysis and big data to be able to take huge amounts of data that we've not had before with artificial learning and intelligence and ways of looking at large data sets that we've never been able to do before. So if we take that capability and able to put that together with strategies of actually doing surveillance, I think we're going to gain new insights by looking at billions and billions of pieces of information that we haven't been able to do collectively. And that may very well lead us to what we would call a hotspot. Oh, okay. Well, here's the strategies. It's RNA viruses. It's going to be at the interface of humans and animals in areas where the environment is being disrupted. All right. Well, maybe that's where our focus then for our surveillance needs to take place. In case there's a quick change, we are able to stop it. Mm-hmm. So our data analytics, I think, will be able to do that. So we have both capabilities. We just need to put it together, and it's not going to be cheap.
Yeah, and that's unfortunately the component of the decision, because you're suggesting that we should pay more attention to countries that are not as rich as we are, and we know that when it comes to how much assistance was given to providing vaccines in COVID, that there wasn't that much generosity, or even you don't even have to call it generosity. It could be self-interest to look at countries where the sources of problem may get worse for yourself. We should be, even out of self-interest, be more concerned about middle income or lower income countries. And so politically, there's just not been that kind of political will.
Well, then we'll continue to
hammering.
We'll continue to have these pandemics over and over with greater consequence. So what I'm saying is, we know what the outcome's going to be. The past is prologue. All these factors we talked about that are creating the perfect microbial storm, or this convergence, right, are not only still in place, they're amplifying and they are becoming even more intense. So our future is pretty well going to be a creation of what we already know, unless we do something. There's a great quote by an epidemiologist named Larry Brilliant that said, "Outbreaks are inevitable, but pandemics are optional." So we've looked at four to 5,000 epidemic outbreaks over the last 30 years. So we kind of know about that. But what causes this major, top 100 of these events occurring? We need to understand that so we can mitigate this from blowing into big pandemics. And we're going to see more of them, and they're going to be more consequential. So that surveillance is one. I think the third one is spanning boundaries. So, you've already talked spanning boundaries. The idea of One Health is really multidisciplinary, it's holistic, it's integrated. And we know in science and ologies, if you will, or disciplines, that major changes usually don't take place in the middle of disciplines. They take place from outside in, where new ideas come from other disciplines, where new advances in agriculture come out of computer science, come out of business, come out of different models. And One Health is the idea of, we need behaviorists, we need sociologists, we need anthropologists to start understanding these conditions. And maybe that's what we need to start thinking about, changing these old ideas that don't really work very well. So spanning the boundary, and you might be interested, or your viewers might be interested in the concept called convergent science. I don't know if you've heard that term. It came out of a paper from Massachusetts Institute of Technology a few years back that talked about we might be in the third biomedical revolution, where the first one was molecular biology, and then it went to genomics. And there are some people kind of pushing on the edge that would suggest that the new biomedical revolution strategy is going to be convergent science. The idea that our problems are so complex and so multidisciplinary that they're only going to be solved in ways that we can make real progress if we bring different teams together to look at different strategies and different innovations. And they say part of that is, funding for research needs to change. We certainly need single disciplinary research. I'm in favor of that, basic research for sure, but we need a lot more team science, a lot more multidisciplinary, looking at this complex web of domains of One Health to really understand what the new strategies are going to be, because that's where the new solutions are going to come from. So the idea of convergent science then is the idea of, establishing new frameworks and new knowledge to fundamentally change how we act and what our new solutions are going to be. So it's an exciting new area. The National Science Foundation in the United States has designated convergent science as one of the key new strategies coming into the next decade, and are funding strategies moving ahead. It's interesting, in Ohio State, we have a group that has kind of organically formed of researchers and they call themselves the wicked researchers. Just the idea of, okay, well, we want a sociologist and we want a pharmacologist and we want somebody out of the public policy, and we're going to pull together as wicked scientists because our old domains of our departments and our disciplines looking at these separately doesn't work. So it's fun to see this kind of creativity now that is coming more of a grassroots up. And they have been given a new National Science Foundation grant of about $500,000 to create a new curriculum for graduate students. So they'll be more equipped with the skills to deal with these problems.
That's
really kind of
absolutely wonderful. I mean, it resonates to me because my notion in creating the Project Save the World was that we have all these 6 global threats that are so interdependent, and yet you have people specializing in one or the other, but they don't talk to each other. And I guess maybe if you put the money there, you're right. The funding is going to be the determining factor in creating interdisciplinary or cross silo interactions. This, to me,
scientific cross-pollination.
Tell me who's going to benefit from reading this document, and is there another step ahead? If you're seeing that you've produced something that is intended to kind of set an agenda for research and for preventive action, public health planning, and so on, who needs to read this document, and whose work would be ideally influenced by it?
So the group that we kind of wrote this for, and why I'm editor, we have experts that have been involved in helping write this, and they're just terrific. They're global experts, and they've written about influenzas and vector-borne diseases and foodborne illnesses and waterborne. So as you read the vignettes in here, they can help you kind of explain the importance of these different factors. So the publication came out of, Council for Agriculture, Science and Technology. So it was the idea of, public health needs to hear this viewpoint from agriculture or from animal agriculture. Much of what's been written about zoonotic diseases had been written through the eyes of public health. Well, this one really not only has public health, but it also has animal agriculture as a key component of this. Mm-hmm. And I think we've done a disservice in the past, Meta, by blaming agriculture for all of these ills and not saying you need to be part of this team. You have a lot to add. You could do a lot in helping us resolve the problem. And you're very susceptible, in yourself. So rather than point fingers, why don't you come along as part of a community health team and be part of the solution? Mm-hmm. So that is part of the background here. Mm-hmm. And antimicrobial resistance and animal welfare and intensified farming, I understand why there's some negative issues about that. Mm-hmm. But you just can't kind of paint agriculture in the corner and say, oh, well, they're the problem when, you're sitting down for 3 meals a day. There's 8 billion people that are eating. And so we need to say, well, what is the strategy then that we can do more together rather than point fingers? We are responsible. We are accountable, and we need to do our part, but let's do it together rather than just point fingers.
You said something, we were talking about the use of antibiotics in animal health, or fattening up animals. They used to use it for that. But what you said was something like this then contaminates the soil. Now, I have a friend, Laura Kahn, who I think did some work on misuse of antibiotics, and she was saying something like, where you feed where the pills that maybe people take can get into the waterway, but also the animals, when they excrete in the pasture, if they've been fed antibiotics, the antibiotics get in the soil and kill some of the viruses or the microbes that belong there, and change the the composition of the soil. Is there any, I never heard of somebody say that there could be any impact on plants. Is there any way in which an antibiotic used for people or animals could also have an impact on the health of plants? And would that be of any importance to even think about?
We're just starting, to learn these impacts. So the last part of kind of One Health is that we understood the exchange back and forth between animals and people, and it goes both ways, by the way. Things like MRSA and some fungal infections will go from people to animals pretty easily. So it's the idea is that we kind of underestimated the role of the environment. We underinvested in it. We haven't really done enough research in it. And there's a whole, what we would call microbiome, right? A whole system of microbes within our natural system, including soils and crops, right? That have, billions of types of bacteria and viruses and fungi, et cetera. And they've kind of stabilized to the point of being able to still grow crops and raise crops, but they're also very susceptible. So you may not know in Canada, but there's a very serious disease in the US called greening disease, citrus greening disease, which is citrus greening disease. It's a disease in oranges in Florida and California that almost is wiping out an industry.
Really?
So we really worry about, here's an infectious process that's taking place, right? And in the world of producers of citrus, it's just as important as some of the other things are, but it is part of this new kind of emergence. So we are understanding then the health of, so one of your 6 challenges is famine, right?
Mm-hmm.
So, we term that food insecurity. So if we have major diseases in corn or maize or in losing half of the hog population in China due to a disease, then we have food insecurity problems. So why that's not a zoonotic disease per se, right? It does impact global health because it infects people's food and nutrition. So these are all related. They're called transboundary disease. So these diseases cross boundaries in nations and go in crops and plants and in animals just as much as they do in people. And food insecurity could be one of the major consequences of that we really worry about. So African swine fever is this disease of pigs that is threatening the United States. We don't have it here, don't have it in Canada, but boy, we would really worry if it ever hit our populations of hogs.
Mm-hmm. But there's no virus, for example, that you know of that could make people or pigs sick and also trees or lettuce plants.
So lettuce and crops become a vehicle for the exchange. Okay. So if you look at a lot of our foodborne illnesses, they don't just kind of come from church picnics anymore. They come from lettuce, they come from nuts, they come from vegetables that have been contaminated, but then they become a source of infection. So they aren't infected themselves, but they are the source of the movement of these bacteria from crops or animals to people. So now there's one group of diseases called fungi or funguses, of which there's 6 million species that really impact crops. And that is a major concern. Mm-hmm. And there is, a disease now in humans and in hospitals that's a fungus that is resistant to treatment. And we worry that resistance may have come to the treatment of funguses in plants worldwide, and the treatment which a group of chemicals called azoles. So Candida auris is the one now that is resistant to treatment to a lot of fungicides in humans, and it's a very serious problem. So we don't know exactly what that interaction is, but it's an interesting one to watch.
Now, when we get sick from eating lettuce that's contaminated, how did the lettuce catch it? Is it in the soil, or was it on the hands of the people who picked the lettuce, or how
All the
is
above.
that transmitted?
All the above. It could be from the land itself that has had, say, it's been fertilized by manure, used on crops, which is a common occurrence. It could be a contamination by people who actually pick the fruit or pick the crops. It could be done in processing, in buildings where you could have infections there, and these materials get washed and splashed and get infected. It could be contaminated in retail, in grocery stores and in stores where there's cross-contamination, in restaurants, or finally, it could actually happen in our homes ourselves where we are not watching what we're doing. We're cross-contaminating in preparing food or not preparing it at the right temperature.
Now, the World Health Organization has been attacked or criticized, and I suppose it should also be boosted. But I guess the question in my mind is if we are seeing this great increase in interdependence among human beings and geographical transmission globally, what needs to be done to strengthen or to empower the WHO? What's the matter there? Or maybe there's nothing wrong with it, but it could be helped further. What would you, if you were in charge of trying to fix the global health issues, how would you treat the WHO?
So I have colleagues that are there. CDC has colleagues that are there. They're really good people. But it's also, so there's four things that we should think about doing. First of all, the World Health Organization is half the size. The World Health Organization is half the size of the US CDC.
Mm.
So put it in some perspective of 190 countries plus, with a capacity then half the size of what the US is. So they're asked to do some things that are almost impossible. So I think one of the things is to understand what the expectations of the World Health Organization should be. And we learned that lesson the hard way in Ebola in West Africa. So I think countries with a really substantial Ebola outbreak in those countries in West Africa thought that the World Health Organization would be coming in and be the troops on the ground, if you will, to take care of this. Well, the WHO is just not designed to do that. They have experts, they give opinions, they set standards, which are very helpful, but they aren't designed to run around and have thousands of people to be able to put at any country where there's an outbreak. So we need to change our expectations of them, and it has to do with their governance. So, I'm very positive about WHO, but they tend to be slow. There's agreement of 180 countries, not easy to do. They are short of, they don't have enough funds, and many of the funds are not equally distributed. You need to look at their finances. Do they have the financial wherewithal to be able to do the things that people want them to do? The answer is no. Do they have an R&D strategy? So, in the last outbreak of Ebola, we didn't have a vaccine. We have an Ebola vaccine now. So what are the strategies going? We didn't have COVID vaccine until now. So what are the strategies looking ahead to develop an R&D strategy to try to prevent things? And then lastly, to be able to develop a capacity within countries and their ability to bounce back or after an outbreak. So I think that the WHO needs to continue. They need to be more flexible, more mobile, and quicker in response. But we need to fund individual countries that have the capacity to see an outbreak early, do something about it. We need to fund individual countries rather than the World Health Organization, so they have the capacity in place to do these things. There was a study done by the World Economic Forum that said, if we would have used money, which would be 2% of what the cost of COVID is for 10 years, we could have prevented this from happening. A 2% investment So if we start to fund capacity, full-time funding in these countries where these outbreaks are likely to occur, and keep a capacity there in their infrastructure, animal and human health, we would go a long ways of preventing or quickly responding to these problems. That is not a WHO issue. WHO might help do the training. They're available for expertise to help with policy and decisions, but those decisions and actions have to take place in country.
Well, that's what bothers me, because now we're back to my concern about the way nations, states control policies that should be humankind in general should be controlling. I mean, I've heard that, you know, China has too much influence, or the country that is putting in the largest amount of money will have more to say about what the WHO does, or any other multilateral organization. That the countries and the funding that's mediated through the system of countries has control over policy to such an extent that I mean, my own approach would be to try to find ways in which funding could come from humankind at large, not channeled through nations, so that you know, if somebody says, here's the next issue that we all need to handle, but there's not sufficient money for it because it would be you know, blocked by countries that are rich, that there'd be a way around that. I mean, I don't want to get into an argument about it, but isn't that a problem rather than a solution? Having more authority being, you know, allocated to national structures rather than the international structures.
Well, I think that's where the finance needs to go. It needs to go to national and perhaps regional systems that are able to respond quickly, and to have a workforce trained in place where you're not just kind of you know, defensively reacting to a problem. You're there to prevent it, or if something does happen and you detect it early, you can bring the resources necessary to prevent it. So that's the strategy, I think, you know, for the future. So that changes the role of the World Health Organization and the expectations. So I don't think they have the governance in place or the finances to be able to do that. That's not their fault. They're just asked to do the impossible to a certain extent. So Meta, you're right. I mean, public health, global health is a public good. It's not just for the people that can afford it.
Right.
And until we get the idea that this is about a public good, about helping all the countries actually end up helping ourselves in a way, right, is a strategy that makes sense both in those nations and in Canada and the US. So we just need to be thinking.
Individual citizens can get that idea pretty quickly, but nations can't seem to get that idea. They're always talking about national interest, and they're always talking about, you know, how are we doing in competition with this other country, and so on. So
we talked about changing the narrative as the first thing, didn't we? The idea we just can't think that way anymore. This is a global good, and we need to strategize accordingly.
Okay, it's been so important as a prologue to a lot more conversations. I'm afraid we really need to talk a lot more, whether it's you and I or a whole bunch of other folks. Thank you so much. I've enjoyed this, and I think other people will find a great value in what you had to say. So it's been a pleasure.
Matt, it's good to visit with you. Thanks for your time and your invitation.
Okay, bye.
Bye.
Project Save the World produces these shows, and this is episode number 531. You can watch them or listen to them as audio podcasts on our website, tosavetheworld.ca. People share information there about 6 global issues, and you can too. To find a particular talk show, enter its title or episode number in the search bar, or the name of one of the guest speakers. Project Save the World also produces a quarterly online publication, Peace Magazine. You can subscribe for $20 Canadian per year. Just go to pressreader.com on your browser, and in the search bar, enter the word peace. You'll see buttons to click to subscribe.